Hey guys, my name is Didi Jimenez, and today we're going to be going over Impetigo due to Staphylococcus aureus. Also known as pyoderma, impetigo is a skin infection that happens superficially due to bacteria, commonly gram-positive bacteria. It occurs on the layers of the epidermis, and this infection is caused by Streptococcus pyogenes and Staphylococcus aureus. And it presents itself as erythematous plaques that have yellow crust. Unfortunately for those that get it, it spreads easily and is highly contagious and can be painful and itchy. Treatment for this infection includes oral and topical antibiotics and also symptomatic care. Contagious impetigo of children and infants was first seen in 1864 by Tilbury Fox. There were many findings thereafter, but nothing new came about until 1917 when a survey suggested that the condition was rare and sporadic. Okay, so now we're going to go over the pathogenesis and epidemiology. Classification of impetigo comes in two categories, primary and secondary. Primary impetigo is when the skin was previously unharmed and healthy, and it becomes affected by direct bacterial infection. On the other hand, secondary impetigo is when the formation occurs due to a previous skin wound. When the skin barrier is disturbed, it allows fibronectin receptors to have access by GABHS, which is group A beta hemolytic strep, and Staphylococcus aureus, which in turn requires fibronectin for colonization. Now the true question is, what causes the skin barrier to be disturbed? Well, the simple answer is things like trauma, cuts, insect bites, surgery, atopic dermatitis, burns, and varicella. So first, the lesion is present, and then it can lead to self-inoculating into other sites. What makes individuals more susceptible? Malnutrition, immunosuppression, daycare attendance, overcrowding, diabetes, and poor hygiene. In terms of triggers, it can be varicella, herpes, scratching, lice, burns, traumas, insect bites. This bacteria comes with many virulence factors, including these three that I've found. Number 1, the possibility of colonizing host tissue due to surface proteins. 2, the inhibition of phagocytosis due to different factors. This means capsule and immunoglobulin proteins. 3, the damage of host tissue due to toxins, which also causes the symptoms of disease. This disease, as I mentioned before, is caused by Staphylococcus aureus. Well, in 80% of impetigo cases. As a matter of fact, it is a combination of Staphylococcus aureus and group A beta hemolytic strep that are the causative agents for 10% of the time. Unfortunately, sometimes it has become more prevalent in MRSA, methicillin-resistant Staphylococcus aureus. On the other hand, exclusively caused by Staphylococcus aureus, bolus impetigo, which is secondary, is the opposite of what we just talked about, non-bolus impetigo, including the complication of an eczema, which is a deep ulcerated infection. Now moving on to treatment and prevention. There are many different options to treat impetigo, including topical antibiotics, systemic antibiotics, and topical disinfectants. In limited impetigo, there is a preference for topical antibiotics over oral antibiotics and are more effective than placebo. In instances where topical therapy isn't practical, the next option is systemic antibiotics, which are for severe and generalized infections. Now let's go more in depth. Let's start with topical antibiotics, which have the advantage of being applied just where they are needed, and in turn avoid gastrointestinal and other systemic adverse effects. How long one has to use these antibiotics depends on the product and how the body is reacting to it. As with everything, there are complications. Some of the allergic reactions include skin sensitization or sensitivity, difficulty applying near sensitive areas like mouth, eyelids, and back, which are all disadvantages of this type of therapy. The common preparations of topical antibiotics are mupirocin 2% or Bactroban, retapulmin 1% ointment, Altobax, and fusidic acid, which is not allowed in the US. Another option is oral antibiotics, which are used with large bolite impetigo or when topical therapy is unsuitable. Normally, this treatment will last 7 days, but sometimes it can be longer if the response to treatment is slow. Although not common anymore because of resistance, erythromycin and penicillin were standard treatments. They are still used, just not as often because of the newly resistant strain. For those that resist initial treatment, there is trimethoprim, clindamycin, and tretinoin. Lastly, we have topical disinfectants, which hasn't had enough statistical power to demonstrate how effective they can be, but they have worked in a few instances. This treatment isn't recommended over topical antibiotics as it is less effective than them. An example of this, the disinfectants, would be disinfectant soap. Now, how do we prevent getting impetigo? Well, hygiene. Wash clothes and hands often. Once you have it, care for the wounds and take the given antibiotics, and you should be good. So here I just wanted to show you guys an example of what it looks like, non-bolus versus bolus impetigo. Picture A is non-bolus. Picture B is bolus impetigo, and it's a rash on a little 4-year-old. As you can see, there's a big difference in both of them. And then this one up here is a 2-month-old with staphylococcal scalded skin syndrome. And there's this one up here on the right. You can see it's all over his little body. But that's just so you can see what the difference is between those three things. Okay. Now moving on to our case study. This is a 10-year-old patient that's from Panama. And he had a fever for 2 weeks, different superficial plaques with hyperpigmentation, and a honey-like surface on the chin. We can see in the first picture in A. Forearm of the right hand, and the inner surface of the left thigh. And these symptoms worsened over 2 months, and that's why he went to the doctor. Treatment did not improve, and the diagnosis of impetigo was believed to be correct. So they took the other option and treated him for methicillin-resistant impetigo. But then again, he didn't get better, as he returned again within 10 days. After thoroughly cleaning the lesions, the patient presented with chronic ulcers with a wet base and high edges. So let's look at the pictures. To the left, which are the first lesions the patient presented with, where he was diagnosed with impetigo and improvement did not occur. So these pictures right here, that's how he went in, and there was no improvement after both systemic and topical antibacterial therapy. With this being said, after coming back, a smear exam was done with amistagotes, where they found, which is this picture here, and they found Lysema Vienna panmensis. As an etiological agent. An intramuscular treatment was initiated, and 11 days after treatment, the lesions were completely healed, as seen in our bottom picture down here. So after they cleaned it, they found stuff underneath, and they did a test that confirmed this, and were finally able to treat him using the intramuscular treatment. So to conclude the case study, to finish it off, it was impetigo leishmaniasis, I don't know how to say it. As a widely spread parasitic infection, LCL comes with complex epidemiological behavior. With this being said, in order to diagnose impetigo L, one must know the diverse and complex pathophysiology of infectious entities within this region. And that is it for my impetigo presentation. On the next slide, I will show you the resources that I used in order to make this presentation. And on this last slide, we have the resources that I used in case you guys want to look further into it. But other than that, that is the end of the presentation, and I will see you guys on the next one. Thank you.